Hello and welcome to Checking the Vitals, a podcast powered by Specialty Care. I'm Todd Schlosser, and joining me today is Ed DeLaney, the Director of Perfusion at Northwell Health, and Dr. Derek Brinster, a cardiovascular thoracic surgeon and Director of Aortic Surgery at Northwell Health. In this conversation, we discuss how perfusionists and surgeons work together to provide excellent patient care during heart surgery. We also examine how vital communication is in the operating room, how innovations happen, and how they are then shared with other surgery teams. Enjoy the conversation. So Ed, Derek, thank you so much for joining us here on Checking the Vitals. I really appreciate your time. I'd like to start out with you, Ed, and then we'll jump to you, Derek, same question. And that question is, can you both sort of tell me a little bit about your background and expertise?
Sure. So I'm Director of Cardiac Perfusion for Northwell Health. I currently work at Lenox Hill Hospital. I oversee Lenox Hill Hospital, Staten Island University Hospital, and the Perfusion School at Hofstra. I'm a co-director of Hofstra's Cardiovascular Science and Perfusion Medicine program. I have a background. I did 12 years on the American Board of Cardiovascular Perfusion. I'm currently on the Perfusion Program Directors Council. I'm currently on the Accreditation Committee for Perfusion Education. I've been a member of AMSEC for years, and I'm currently a member of the Academy. I've been a member of New York State Society. I'm a director for that. That pretty much sums up a little bit of the background.
Okay. Derek, do you mind talking a little bit about your background as well?
No problem. I am a cardiovascular and thoracic surgeon. I've been in practice about 20 years. I was originally began my practice in Richmond, Virginia, Medical College of Virginia. My interest is in complex aortic surgery. And I was director of aortic surgery in the heart valve program there, and then moved up to New York City about 7 years ago to join Northwell Health. Northwell Health is one of the largest healthcare enterprises in the United States, has approximately 30 hospital systems, and we have 4 hospitals that do cardiovascular and thoracic surgery at this time, and many other hospitals who do thoracic surgery, lung surgery. My interest is in kind of overseeing the aortic surgery program in the cardiovascular service line. We have one of the largest aortic dissection programs in North America at this point, and we've had rapid growth for a number of reasons over the last 7 years to add to that. And my training has been in complex aortic surgery, both open and also especially endovascular surgery, which is where we use needles and wires and can deploy aortic stent grafts to treat a lot of the pathologies that we're confronted with.
Excellent. And thank you guys both for sort of setting the groundwork of sort of how you grew up in your careers to sort of make you as successful as you are today, and which is why I sort of wanted to talk to both of you because, and as you mentioned, Derek, you guys focus on aortic cases. And I wondered if you could, very high level, give us an explanation of what an aortic case, just a general aortic case would be.
Well, at a high level, the heart pumps blood into the aorta. The aorta is the major artery of your whole body. Yeah. The aorta goes up to the head, down the back, and then into your belly, and then feeds the legs. Along that way, it feeds every arterial system. So diseases of the aorta typically involve being an aneurysm, which is when it grows to twice the normal size, and that can burst or rupture, or dissection surgery, which can happen in an aneurysm or it can happen without an aneurysm, which is a rip in the layers of the aortic wall that can lead to rupture or to death, etc. So those are the 2 primary focuses that we look at. We also have a very large program regarding aortic valve surgery and aneurysms that happen at the very first portion of the aorta down by the heart, and in valve reconstructive surgery as well. So that's a broad overview.
Sure. Thank you for that. So how many aortic cases would you say that you handle every year?
So currently, Northwell Health does approximately 140 type A aortic dissections per year. We do over 500 aortic aneurysms per year. And in terms of my current practice, I do approximately 150 aortic procedures per year. ballpark.
Sure. I mean, I'm sure that varies year to year by a few cases, but around that number every year.
Absolutely.
Which is quite a lot, which, I mean, with these highly specific and highly skilled surgeries, you do want to get as many, for lack of a better term, touches like you would in like baseball or soccer or whatever to get more hands-on practice. And the more you do, the more you learn and the better you get.
Absolutely agree. And that's one of the most important things that we tell our patients when we look at aortic root surgery, which is the surgery at the first portion of the heart. North America heart surgery hospitals on average do only 2 of those a year. And
wow. Okay.
So when we do, we do approximately 80 aortic root surgeries myself alone, and about 140 for the healthcare system. So we know that there is, like you said, those touches, or like I like to say, the Henry Ford model of quality, because the more repetition you get, you reduce that variance. And we actually have seen in the data, and our data, and also other national data, that around 35 to 40 aortic root procedures, you have a significant decline in morbidity and mortality afterwards. So you're absolutely right. It's a specialty field that should be done, if possible, by specialists. And that's not just me, but it's the whole team and perfusion, et cetera.
Well, yeah, I mean, I do think that because of, and maybe it's because of pop culture, like Grey's Anatomy and stuff like that, that people see a surgeon as a one-man show or one-woman show, and it really is a whole team involved in pretty much every surgery. And of course, we're going to talk more about aortic cases in this context, but which is why we have a perfusionist, or the head of the perfusion team that you have there, to talk with as well. Because, and Ed, you can talk about this more in greater detail, but you guys are a vital instrument in that room, keeping the patient alive on that heart and lung machine.
Right. So every aortic case that we do that's open, barring the TVARs, goes on the heart lung machine. And it really takes a team effort. And what we're doing, essentially, we're always training for aortic surgery too. This way, we always have backups. We're one of the few centers that actually train students in complex aortic surgery also. A lot of centers that train students, they'll give them kind of the softball cases, if you will, cabbage, simple valve, maybe a double valve, things like that. What we do is we throw our students in with 2 experienced perfusionists to kind of train them up on these complex surgeries. And then what we like to try to do after that is hire them, because they're already trained up in the style that we have. They already understand the complexity of the surgery we do. So we're always training. It's not, if we do a complicated case, we have a student in there, or we have a younger perfusionist in there, because we always want backups. I can't be the only one that does it. My senior perfusionists can't be the only ones that know how to get through these difficult cases. So we're always trained. And one of the big things that we'll talk about, especially during this conversation, is the importance of the training and closed loop communication. It's probably, obviously, besides paying attention, the most important thing we do is accurate closed loop communication between perfusion and the surgeon, and making sure that the room understands what's happening. One of the unique things that we have going on in the operative theater is we have all the surgeries on a monitor. So the perfusionists have a direct view of the chest, what Dr. Brinster is seeing. So we can help anticipate things that may happen or things that are currently happening at the time. So besides your set of vitals, besides looking at the field, we can now look directly into the chest at the surgeon's view, which has been very helpful. And that's probably how long, about the last 2 years, 3 years?
I would say yes.
So your perfusionists that are working these aortic cases are actually seeing, the operation take place on a monitor, all while also running their equipment.
Correct.
Okay.
The interesting thing is, if there were a problem, and I would always have 2 perfusionists in the case, we would actually have one go up the head of the table and look directly into the chest, over the drape. And now we can actually just visualize it on the screen.
Yeah.
It's a very seamless kind of system right now.
Yeah, it makes sense because you can literally look up and see exactly what the surgeon sees. And I'd imagine, I don't know what they are, but there are some visual signs that something is going wrong. And I mean, so you guys are cued into that almost as fast as the surgeon in the room is cued into that because you're both looking at the same thing.
Well, we're all looking at the same patient, working the same goals, and when you're in the intensity of difficult surgeries, it's good to have help there. The surgeon helping me to help him essentially with that closed loop communication. And if I can see anything or can be keyed into anything that can help him better by visualizing it.
Yeah. Now, this is second or third time you've actually mentioned closed loop communication. When you say that in this context, what exactly does that mean?
So the surgeon will give a command. I'll repeat the command.
Right.
Or if there's additional information, I'll give additional information and he'll affirm the additional information, or vice versa.
Right.
If the original command starts or not, if the original command starts for me, whether it's if he's saying we're going on bypass, I say going on bypass. Then I'll say I'm on bypass. I'm at full flow, and he'll acknowledge that, and vice versa. I'll acknowledge his communication back to me.
It's a very critical way of making sure everyone is on the same page. And I can't imagine a higher stakes situation than this type of surgery. So you don't want to leave room for error like that. So I feel like the closed loop communication is very important.
One of the things we do with the younger perfusionists and the students is we're really focused on exactly what they're telling the surgeon and how they're saying it.
Yeah.
This way there's no confusion. We really don't want them to add anything to the commands. We don't want them to have too much verbiage where it confuses the staff, or it kind of takes away from what's going on in the surgery.
With a younger perfusionist, I wonder if maybe they're pumping their first few cases on their own, or, where they're the lead perfusionist in the room. Are they ever nervous to say, hey, there's a problem. Hey, hang on. We need to stop doing something. Something's not working correctly. Like, how do you address those sort of issues where someone may not be comfortable speaking up in that setting?
I can probably answer that in a number of different ways.
Okay.
First, I think it depends on their training and background and how they're going to deal with the appropriate situation. So what we try to do and train them to do is always speak up and have the moral courage to kind of speak up and state what's wrong and how they can help. But the other thing we do is we really don't believe in that old baptism by fire type of training. By the time they're doing these complex surgeries and flying solo or with a second person, and because with the larger cases, we try to have two perfusionists in the room.
Right.
And one is essentially pumping the case and paying attention to the patient. The other one is charting and being a second set of eyes in the room and basically getting anything that perfusionist may need, whether it's additional drugs, whether it's additional fluid. It's more the majority of the time it's a second set of eyes, and this way they're not distracted by charting and things like that.
Sure.
But the entire time we do training, even with younger perfusionists or even mid-level perfusionists that come into the system, what we're trying to do is explain to them the little idiosyncrasies that make this a good, smooth transitional case, and what helps the surgeon essentially, and what the feedback should be to the surgeon for that closed loop communication, and just little things that'll help make the surgery a little easier. And I can probably talk about, we do large number of thoraco-abdominal procedures at Lenox, and they're difficult cases. They're open cases, and that communication is so important because essentially what's happening is you're perfusing the lower half of the body with the heart-lung machine, and you're perfusing the upper half of the body with the patient's heart and circulation. And we're holding blood back, so we're not draining the patient out totally. And it's an actual balancing act of keeping enough volume and blood in the patient so they can perfuse the head vessels, and then making sure you have enough volume in the heart-lung machine that you can perfuse the lower half of the body when Dr. Brinster is fixing the aorta. And Derek, you can probably speak to that a lot better.
I think a lot of key points is the absolute control of communication that has to happen between perfusion, surgeon, anesthesia, and anybody else of importance in the operating room for the team to conduct their surgery safely. And what Ed was talking about in terms of the closed loop is probably the most essential thing: a calm, closed loop of communication without distracting conversations happening outside of that loop is essential for these complex cases. And that's what we abide by.
So is there something that the surgeon can do to create an atmosphere that's more conducive to that sort of feedback that may be perceived or negatively received, maybe?
To Ed's credit, they do a lot of student teaching on a lot of complex cases. And I think that when they see the way that Ed's team responds is the way that they mimic and learn. And what we do as surgeons and as staff at the field, the operative field, is that we encourage that, we'll say, hey, did you hear me? Please close the loop. Tell me, if we ask for, say, the left ventricular vent off, and they say, LV vent off, I say, is it going off? Because we need to know kind of what we're doing in terms of time. And so we do all have the same game plan in terms of educating those students in terms of proper feedback. And even, as professionals, we make sure that we have feedback among the anesthesiologist, surgeon, and perfusion to get the whole culture to realize that this is something important. This is something that we just don't say to do, but that we actually practice.
Yeah. Now, you mentioned that, and Ed, you maybe can speak to this too, but you train on these complex aortic cases. How many out of the aortic cases that you guys do every year, how many of those are complex aortic cases?
I think that almost all of them require circulatory arrest. In fact, I think probably, over 90% of our aortic cases have some form of circulatory arrest in which we cool the patient down. We stop the systemic blood flow to the lower body, typically perfusing the head. So those are all complex. So we do over 100 complex cases at Lenox Hill alone, and over another 100 at North Shore Manhasset for Northwell Health. So we do quite a bit of all complex cases. Now we have about 20 to 25% of our volume at Lenox Hill is reoperative aortic surgery, typically sent from other cardiac surgeons who do other heart surgery, but don't have a specialty in aortic surgery, let alone reoperative aortic surgery. And those are highly, highly complex. But even then, a lot of times the senior students do participate in that as the primary perfusionist.
Yes, I just want to go back real quick because when we were talking about the communication, the one thing and the one area that I think is probably the most appropriate time to do it is tone of the voice and essentially commanding the room. When we're having a conversation, a good perfusionist can pick up on the tone of the surgeon's voice and when something's more serious than it was a few seconds previous. Sure. And when a surgeon may be having trouble with a part of the procedure where we would need absolute silence in the room. And I think that picking up on those keys of when we are at a critical part of the surgery and when there's a more relaxed part of the surgery, I think is very important. And that's some of the stuff that we do train up in those more difficult cases.
Oh, I'm sure. And it sounds like, at least from what Derek was saying, that you guys get a lot of complex cases there. So you get a lot of training on that. And I'd imagine that situation where we need absolute quiet in the room, we got to close all these loops in communication. Like, I'd imagine that happens more in these more complex cases. Obviously, correct me if I'm wrong, though.
Yeah, absolutely.
One of the things I like to focus on this podcast is innovation in the medical space. And obviously you guys focus a lot on aortic cases. So I was wondering, over the course of your past, 3, 5, 10 years, what has changed the most? Where do you see most of the innovation in that time?
So I think that the biggest innovation for aortic treatment, just in general, is the move towards more endovascular therapies, either as a total treatment plan or as what we call a hybrid treatment plan, in which we have some endovascular where we use a needle and a wire, we put a stent graft in a position in the aneurysm or dissection, And then we either have a complete planned success, or it's a plan to use that stent graft to kind of reduce the morbidity of another procedure that requires open surgery. I think that in terms of a treatment plan are the waves of the future. Northwell is currently one of the few centers that is participating in a stent graft that actually covers everything from the ascending aorta arch and descending aorta that we're very excited about. I think in terms of perfusion, our circulatory arrest strategies have undergone a huge shift in the last decade at innovative centers, where it used to be that we would cool the patient down to profound hypothermia at 15 degrees Celsius, and that works well. The issue is that it's a very long cardiopulmonary bypass time, and also leads to potential for a higher bleeding risk due to the cold coagulopathy that can ensue. But in the last decade or so, there's been a move to more moderate hypothermia, where we cool to approximately 26, 28 degrees Celsius with selective antegrade cerebral perfusion, where we can perfuse the most vital organ, the brain, cool the kidneys and the rest of the body down to an appropriate level that allows us to have success and not any kind of danger to the lower body. Because we know that around 26, 28 degrees, the kidneys require only about 30% of the oxygen demand. And when we do a clean aortic case, our circulatory rest times tend to be short, and the body is perfect afterwards, and so is the brain, without having to cool all the way down. Ed, what do you think?
Yeah, I think when you talk about innovation, I think the last few years, what we've done with some of the hybrid procedures where you have like an ascending hemiarch, and then you're putting a stent graft down into the thoracoabdominal area of the aorta.
Absolutely.
I think they're pretty impressive. I think the fact that we're doing third and fourth reoperations on the aorta is, previous to the last 5-10 years, nobody really did that. I just think that surgically, it's become such a fine, well-oiled machine. And the technology's advanced, and our capabilities have advanced, and our protection strategies have advanced to the point where we can do these more complex surgeries. Just talking about protecting the brain, how we do the antegrade cerebral perfusion and retrograde cerebral perfusion.
Correct.
In the past, you saw either one modality or the other. So surgeons would either do antegrade cerebral perfusion, or they would go retrograde cerebral perfusion. And this was usually based on the current literature or where they were taught how to do the procedure. And what you're seeing now is the data mining becoming a lot better. And we're able to see even what we're doing with a combination of the protection strategies. So you could probably talk to your reasoning to switching to antegrade cerebral and then followed by retrograde cerebral perfusion.
I think, in the last 3 years, Emory University with Brad Leschenauer published a nice paper that was randomized to antegrade cerebral perfusion versus retrograde cerebral perfusion. What they found was that non-clinical small emboli with antegrade alone happen in about 80 to 90% of the patients. And when you use retrograde cerebral perfusion, they only had about about 10 to 20% of patients. So there's a washing out effect that probably is happening with retrograde cerebral perfusion. So we like to have the benefit of the antegrade cerebral perfusion that we do for about 90% of our circulatory arrest time with selective antegrade. And then the last 10% of that time is retrograde to kind of do a washout of embolic debris, air, etc., that may be leading to those non-clinically present embolic phenomena. I would also like to state that one of the other innovations that we've done over the last 5 years or 7 years is that we now do almost all of our primary aortic cases not through a full sternotomy, but we do it through a minimally invasive sternotomy, which means that instead of having to separate the entire sternum, we leave the majority of the sternum intact. And we do AVRs, roots, ascending aortas, hemiarches, all through this small incision. And people are under the assumption that's for cosmesis, but it's really not for cosmesis. That's a secondary benefit. The real reason we do is that a lot of these aneurysm patients tend to be older, maybe a little bit more frail. And we know if we preserve that lower portion of the sternum, their pulmonary mechanics, their breathing mechanics after surgery are superior than if you did a full sternotomy. Their pain is less, and their return to activities of daily living is much more rapid because they don't have their full sternum open. And I think that's one of the, differentiators between Northwell Health and a lot of other aortic centers is that we've really gone to this minimally invasive approach and have had excellent outcomes in terms of patient, satisfaction,
Sure,
recovery, and without any kind of detriment to the safety of the operation.
that's one of those things that when you say it, it makes complete sense to me that, you're not having to open the sternum. So that remains intact. So there's no healing that really needs to take place there. The piece of it that I wouldn't put together is that helps breathing function, which of course it does, but I just wasn't thinking about that. That lowers recovery time post-surgery. Of course it does. That makes complete sense. And it sounds like out of all the innovations that you guys mentioned, the switch from what I would say sort of a fully invasive to a minimally invasive approach there is the only one that I think was, or it sounded like was instrument driven maybe. The rest were technique driven. And I wondered if you guys sort of see yourselves in the front line of at least the technique driven side of it, because you do have so many touches, or the Henry Ford model, as you put it earlier, you have more of an ability to innovate with approaches because you have more touches on the patient.
I think that's absolutely true because, when you have so much repetition, you can identify areas for improvement that make sense to the providing excellent patient care. That if you were only doing a few scattered a year, you would not be able to identify those little tweaks to improve outcomes. And
Sure.
I think that's absolutely, you hit the nail on the head with that. It's the volume that we can, always have, QA, QI, debrief and say, you know what, maybe we should be doing it this way. And that's where a team approach that is open to communication and instills the confidence in all team members to participate in that communication is so essential. So, Ed will come up and say, we should think about doing it this way. This is probably better. And I would say yes or no, but at least there's a discussion there and vice versa. So if there's a discussion that's open to innovation, because that discussion has to be there for innovating to work.
Absolutely. And I'm sure it has to be collaborative, as you mentioned. You guys go into a room, you debrief. Ed might bring up, hey, maybe try this next time. And you say, yeah, that might be great. Or, we can't do that because of this, or whatever that collaborative effort is, right? You're coming together to think of a better way to provide patient care ultimately, which I think is everyone's end goal, right? So when you do come up with, say, an innovative approach or just a different way of doing things, either of you, sort of how do you disseminate that information to the people who are sort of in your charge? So like Ed, other perfusionists that are under your supervision, or Derek, other surgeons that work on your team. How do you sort of disseminate that technique or information?
What I'll do is I'll bring back to the team. We'll have a discussion, and then Derek and I'll think through something, or the team and Derek and I'll think through something. And I usually do it first if it involves the heart-lung machine.
Sure.
And I usually have a second set of eyes in there just to watch and make sure of everything going on around me, and if they can see a better way to do it. The good thing about having highly trained people is that they can pick up on these things, and even if my original approach is not the best way, we can come up with a better approach the next time. And I think it's important to understand that some of this collaboration between the surgeons and the team and the perfusionists, it's more unique than you think. So there are a lot of programs that it's very top down instead of that collaborative model. So
Sure.
We do have a very good collaborative model, which is it's definitely more unique than the standard. So.
And then Derek, when you guys come up with a new surgical technique, how would you disseminate that to other surgeons that are in your charge?
Well, we often talk about these at our monthly conferences if there's been a significant advancement. and discuss as a team throughout the healthcare system, kind of how we're trying to protocolize or make sure that the quality and procedures remain consistent. So as Ed pointed out at the beginning of this talk, a lot of the things, some of the innovation has been that we do what's called a frozen elephant trunk, where we deploy a stent graft during circulatory arrest. And that procedure is not very common with other surgeons. So what we did is we had a didactic, a tutorial where we had, prosthetic models, and we had the device companies come in with some samples that all of the surgeons could get their hands on and learn how to do it. And since that time, many other surgeons have started doing the frozen elephant trunk when they have to do aortic surgery. So it really does work out in terms of dissemination. And I think, as Ed said, you need to have a culture that's open to dissemination for improvement. And I think once you drill into people that, we're here to provide, our mission at the bottom line is to provide excellent service to the patients that we serve. And everything else should be secondary. And once people understand that, they're much more open to changing their practice patterns to achieve those excellent results.
I mean, that makes complete sense. Obviously, I really like how you bring in sort of everyone. Once you've sort of developed a new technique, you bring in students from the perfusion side, maybe even medical students as well, or people in residency as well, and medical device manufacturers and everybody, to come together to learn in a safe environment how to practice it, how to do it, and then they can go back and implement it themselves, having practiced it in a safe environment.
Absolutely.
The health system has a Bioskills Lab that both Eric and I participate in, and that's another training layer that we have, and it's partnered with Hofstra, so the medical school, and the Hofstra perfusion students all are in this Bioskills Lab, and it's multidiscipline. And so you'll have surgeons, anesthesiologists, you'll have perfusionists, all in the same room, learning different skills and kind of collaborating with each other. Derek, you recently just did one with the fellows, correct?
Yes. So we were out there just 4 days ago with there's your perfusion students. We had a kind of synthetic model that was actually on the heart-lung machine that they run through different scenarios of air embolism, dissection, et cetera, that the residents and fellows for surgery were participating on complex aortic reconstruction. We did some aortic root valve sparing procedures on a cadaver. So there's a full armamentarium, as you said, to safely practice. And I think that's one of the keys, is that we're educating and then we're practicing, establishing good practice patterns so that they can perform in a safe way when they actually do the aortic procedures.
I'd imagine that concentration on making sure we do it in a safe environment correctly every time before we do it in a live OR setting makes you, Derek, a lot more comfortable as a surgeon when you might have like a perfusion student in the room pumping a case as the primary perfusionist. Does that make you sort of relax knowing that they've done it a few times in a simulation setting?
Absolutely. So I can see that the students, there's a big transition between their very first few cases and their last few cases. I mean, as Ed and I have talked, there's a few, students at their end. I'm like, wow, those guys, we got to try and keep them at Northwell. They're really good. So, I mean, you can see this transition that they've practiced, and during their training, they've had repetitive time on that simulator to kind of get the skills, react to, challenging circumstances, be able to think through those challenging circumstances in a logical way without getting panicked, et cetera. So it really makes a tremendous difference, I think.
And Ed, I'd imagine as the person who's sort of in charge of that program, that you sort of relax knowing that you have a student in the room, knowing they've done it a few times in a simulation.
Perfectly. Absolutely. The one thing that we do is we train the students from day one on the equipment that they're going to see in the clinical rotation. So we have circuits from Northwell Health. We have circuits from Columbia, NYU. So we're training them on the action. It's almost like a modern day apprenticeship. They're going to be using the same technology when they get out into the field. We're training them the same way with the surgeons. We're training them in an environment where they're doing that closed loop communication with anesthesiologists, with surgeons, with each other. The nice thing that we always say is that they're getting to the surgeons before they're surgeons. So when they're in their training and it's that kind of a brother in arms trench mentality that we've all gone through this together. So that's very unique for perfusionists to do that with any kind of physicians. I'm almost positive we're the only school in the country doing it. So, and I think we're the only health system that's doing it that way right now too.
It would make sense that you try and, after you train these perfusionists, you try and hang on to them because they are trained both in the systems that you use and the techniques that you use, but also the culture that you guys use, which I think is also extremely important. It sounds like in your culture of, doing it in a safe environment, communication being so important, all of these things have what led you guys to be so successful. So you want to hold on to people who know the skills, know how to do things correctly, and also buy into that culture.
Yep. Derek had mentioned about some of our processes and protocols and how as a team we revise. And one of the things that he's brought to Northwell is basically, and this is it's a complex ambulatory strategy, how we have direct to the OR for these kind of patients. So even when they're in transit, they're in constant contact with Dr. Brinster, and what's happening is he's telling them where to take them, whether it's Manhasset Hospital, whether it's Lenox Hill, so that they get to the hospital as fast as possible. And they bring them right into the operating room, and we scan them on the table. They don't go to X-ray. They don't go to any kind of holding area. They're literally from their house into the OR, which is it's unique. It's very impressive, and it saves most of these people.
I mean, I'd imagine, and obviously correct me if I'm wrong, because you two are the experts, but time is a huge factor in these types, especially of these sort of complex cases.
Time is of the essence. We know that there's a mortality rate that's measured in, every 30 minutes, et cetera, for a lot of these dissections. So as Ed was saying, we've been able, because of such a large volume, to kind of establish a protocol with our EMS service where we have, obviously a centralized emergency medical service that's extremely large. They use, AI, artificial intelligence, to actually be able to start circulating ambulances around a particular area of the 5 boroughs of New York, Westchester, et cetera, and Long Island, to make sure that they're ready and prepared. One of the issues that we were having was that the ambulance would pick up and go to the closest hospital as per routine, but they wouldn't have the expertise to treat the patient there, and then require another transfer. And that's a huge time loss. And then when they actually did make it to the hospital, they go into the intensive care unit. And then once they got the intensive care unit, they would go into an operating room setting. And sometimes in that operating room setting, they wouldn't have an endovascular hybrid operating room for a dissection. So now we've condensed that and literally saved hours of time between that transfer process with the close work with the Central Emergency Medical Services to streamline from the start of this disease process their treatment. And that has made a tremendous impact on salvaging these patients.
Oh, I'm sure. As you mentioned, time is a factor.
Absolutely.
So let me start with you, Derek, but I'd like to ask each of you if you could sort of give one piece of advice to surgeons and perfusionists with these sort of complex aortic cases. What would that advice be?
I would say one is that specialty training is essential. When I finished my aortics or my cardiothoracic fellowship up in Boston at Brigham and Women's, I spent a few months down with Joe Bavaria at University of Pennsylvania. I also spent a few months out at Arizona Heart Institute with Ted Dietrich learning endovascular. And that is essential. And if you're going to do endovascular, you have to be involved on a repetitive basis because it's a skill that will quickly erode and go away. It's a perishable skill. If you want to do aortic surgery, you have to go to an institution that does aortic surgery, or there's a market for aortic surgery. And it requires a lot of hustle. And you need to try to say, if possible, that you will handle every emergency, whether you're on call or not, and come into the hospital all hours of day and night And it does require some personal sacrifice for sure.
Sure.
But, the trade-off is that you develop a reputation, you develop a skill set, you get comfortable with the most extreme cases. So when you do routine cases, they're very easy or easier. That would be my suggestion, is training. First job is essential to have aortic volume, requires some sacrifice in terms of, perhaps your quality of life. If it's you're going to sacrifice some of it, but you're going to have a practice if you want it. And that's really what's required.
I'll take it in a little bit different direction. I
Sure.
think that it starts even when you hire people into your team. You have to hire very coachable people. You have to hire people with the right temperament. The skill set, you can train some of that in. They definitely need the background, the repetitions, and the expertise to do this. But I think the fact that you want people that are going to go the extra mile, that are going to always do the right thing at the right time, and not be afraid for a second set of eyes, and use their checklists essentially to go through and make sure you set up the right way and take the time and basically get two sets of eyes on everything.
Well, Ed, Derek, thank you so much for letting me take up a lot of your time today. And I'd love to do this again in the future as more innovations come down the pike in your area.
No, it's been a pleasure being here. I really appreciate this opportunity. Thank you.
Absolutely.
It's a really great opportunity. Thank you. Much appreciated.
Absolutely. Thank you for listening to Checking the Vitals. If you enjoyed the content we provide, please leave us a 5-star rating and review. It really does help people find the show. And make sure you subscribe so you hear our interviews with healthcare innovators every Monday.